Let's talk about some of the ways in which providers can and should deal with opioid use disorder. And let's start about when you're talking about with a substance abuse disorder.
Well, let's talk about with the use of medications for one.
Okay.
When Data 2000 was passed, it had a little thing in there that called for providing psychosocial services to patients who needed it. It didn't require it like it does in a methadone system, but it recommended that a physician who was treating someone who needed psychosocial services in addition to the medicine would have the ability to either provide or refer that person to services. Looking at those data over time, about 10% of patients who are entered in medications for opioid use disorder, MOUD treatment, receive psychosocial services. Doctors' offices just aren't set up to provide it. They have nurses who work for them. They have phlebotomists who work for them, but they don't have social workers who work for them. And sometimes, even if they wanted to hire social workers or clinicians to do the work in their office, the states in which they operate have requirements about getting licensure if you're providing services to someone with a substance use disorder. And you have to go about getting a separate license and carrying on a lot of other reviews that you wouldn't do if you were just practicing medicine. So it prohibits the provision of these services. Additionally, if those patients are receiving public entitlements, Medicaid and Medicare for the medication part, they wouldn't be eligible for reimbursing the office for the services that the social worker provided unless it was coming through the grant and aid system in the state. So there are lots of barriers to providing comprehensive care in the doctor's office. Therefore, we have come to a point now where we see that only about 10% of patients who receive MOUD in the doctor's office receive comprehensive care. Now, there are those who've written and argued that the medications alone are curative, so you don't need the psychosocial services, but I've rarely met someone with a substance use disorder that couldn't benefit from having some talk therapy go along with the medications. And so we don't have a system that provides for it. But there are some solutions that are coming online, the prescription digital therapeutics. And there is one that is FDA approved that I can actually write a prescription for my patient to receive psychosocial counseling through a prescription digital therapeutic. And they can take that along with the medicine that I've been prescribing. The challenge there is this is a new area of medicine. Only one of the app-based services that is out there has gone through the FDA review. And until there's FDA review and approval of these things, we probably aren't going to get a reimbursement code for them. And right now, if you are taking that service, you're either on a self-pay basis or you're using it through their compassionate use program. So it's not widely available. I think there's a lot of potential for prescription digital therapeutics to close the gap and to be provided along with telemedicine-based opioid therapy or even bricks and mortar office-based opioid therapy to get these services to the people who need them. But there's more work that needs to be done there. And unless and until these new digital therapeutics go through FDA approval, they don't have built into them all the privacy protections that we as people in the field believe should be built into them.
What happens when you take that substance abuse disorder out of the equation? How does that change treating the opioid use disorder?
So there are people who have, singularly like opioids, use them and only use them, but rarely do we see people who don't use other substances, particularly sub-end things when the opioids aren't available to sort of take the edge off of the deficit of opioids in their life. So if you have someone who is a pure opioid use disorder, getting them into a methadone program or a medication for opioid use disorder program is great. If you have someone that's using other substances, medications alone don't address those other substances. And the person who is writing the prescription for buprenorphine in that instance has to be aware as to whether they're using benzodiazepines for sleep or anxiety or back pain, if they're being prescribed that or taking it from the street, or if they're using alcohol on their own or smoking marijuana in addition to the opioid. And again, the buprenorphine does nothing to address those other substances. That's why, in fact, psychosocial services need to be employed and other kinds of manualized treatment that the National Institute on Drug Abuse have developed for these other disorders. So, for example, contingency management services for the stimulants has been manualized and shown to work through NIDA so that you can actually give people rewards the longer they stay off the substance. And being able to employ a variety of strategies along with the MOUD is what we have found works best in the long run. Some treatment's better than none, more is better than less, but treatment is best when it's driven by assessment. So you know all that they're doing. It's buttressed with case management, and if the person goes away for treatment, it's completed with follow-up care in the community. Now, MOUD is obviously treatment that takes place in the community, but the medication alone may not be enough for someone who has uses a variety of substances.
Does alcoholism change that equation at all, or what does that do in that process?
Well, alcoholism presents some challenges at the outset because in order to stop alcohol, you generally need to have at least a medically monitored or managed system because alcohol withdrawal can in fact be life-threatening. So that's presented some challenges in the age of COVID, in terms of bed capacity in detox facilities and bed capacities in hospitals. And there are some psychosocial detoxification programs that are run in the not-for-profit arena where patients were asked to go through an emergency room to get certified that they could be admitted into these non-medical settings for withdrawal from their alcohol. And again, the emergency room is not a safe place to be if you're trying to avoid COVID. We don't actually have medications for the maintenance of someone like we do for OUD for alcohol. So it's abstinence-based treatment. Mm-hmm. You've got to first get them off, and then you've got to get them to stay off. It's in the words of Terry Rustin, who writes about quitting nicotine. You got to quit and stay quit. People know how to quit, but staying quit becomes a challenge. And it is for tobacco, it is for alcohol, it is for many, many of the substances. And being able to figure out what is going to enable that person to stay off of drugs once they quit, or alcohol or tobacco once they quit, is what happens in therapy.
And finally, how does that equation change for a patient who is being treated for a mental disorder?
So the mental disorder can precede the substance use, or the mental disorder can follow the substance use disorder. If it precedes the substance use, and this is something that you have to sort out through history. So if it precedes the substance use disorder and the person uses substances because they've not had an adequate assessment of mental disorder and been put on appropriate medications, they may be self-medicating that. And when you take the drugs out of their system, and I use medications when I talk about it being prescribed and used appropriately by a doctor, I'll call even a medication a drug if a person is self-administering it without the the service of a physician managing that. So if a person is using a substance, whether it's a medication or a street-acquired medication or a drug, to manage the way they feel from a mental disorder, and you ask them to stop, that mental disorder becomes unmanageable again. So you've got to be able to assess whether there's a co-occurring mental disorder and whether there are medications that can reduce the symptomatology of that so that the person can function. And sometimes the symptomatology of that can be reduced with prescribed medications. Sometimes the symptomatology interferes with them engaging appropriately in treatment services. So if someone has an anxiety disorder and they don't do well in groups, they're probably not going to be able to respond to going into a residential treatment facility if their anxiety is not addressed. And if they leave treatment and then don't go to 12-step meetings afterwards because they are too anxious to go, they're not able to engage in that part of their treatment plan, they may be setting themselves up not to be successful after the treatment episode. So it's important that treatment providers be able to assess both the order in which these things are acquired and then to determine whether there are better medications than the drug that the person was using to treat the underlying mental disorder.